going to get ready for this next session. We know that overweight and obesity are hard topics, aren't they, to talk about, particularly in social and clinical settings and in the media. The next panel session will cover the topic, can we agree on how to talk about higher body weight? And I'm pleased to welcome back to the stage Dr. Norman Swan as moderator for this session. And joining Dr. Swan is Tiffany Petre, Obesity Collective, Laureate Professor Clare Collins, University of Newcastle and Hunter Medical Research Institute, Dr. Fiona Willer, Health, Not Diets, and Asmaa AbdelGawad, Community Representative, Health and Wellbeing, Queensland. Please make them all welcome.
Thanks very much. I mean, I want to start by, so by the way, we're going to do this slightly differently. I always get a bit frustrated. We'll leave this to the end for you to ask your questions, and the moment's gone. You've got something to contribute. So if we're yakking on about something that you've got something to say or disagree or want to add to it, put up your hand. We'll get the microphone to you. I'm not sure who's carrying the microphones, and we'll bring you in to the conversation in real time rather than waiting towards the end. So we'll have an opportunity at the end, but let's have a whole of room conversation, because I think this is a bigger conversation. We're just the stalking horses, if you like, for the conversation. It's one that involves all of you, and and there are some uncomfortable things about it. I mean, I was talking to Magda Zabensky, who I had on the show this week. So she's done this 3-part series for the ABC called what was called Big National Health Check, and she's been trolled on Twitter, saying, basically fat trolled. And, she kind of knows that she shouldn't she shouldn't engage, but she did and gave as good as she got, as you would expect from Magda, quite funnily often. But, huge issue and some awful things being said. So how do we talk about this? And can we be too ideologically pure and we get so tangled up? And I'll give the example of Aboriginal communities now. I think non-Aboriginal people get tangled up in, how do I talk about this stuff? How do I refer to it? And then when you get to know Aboriginal communities, all they want is respect and not to be patronised and to be culturally appropriate. And you just be yourself and not get too caught up. And obviously, you're not going to do that if you're racist, but we can be just too fearful in this situation. Are we too fearful? What's the story here? Do we put off people by the way we refer to them? Clare, you and I were on Biggest Loser. I was the medical host, and you were the nutritionist behind the scenes. And, well, certainly I was accused of contributing to stigma and obesity through that show. What did you think when you were on it?
I was really proud of contributing to keeping people safe from a nutrition point of view as part of the medical team behind the scenes. And I think what we know now, I don't think that show would run even if it came up now. We certainly have moved on a lot. And one of the really key things, I think, is that we don't talk about weight in the context of health, and we never talk about nutrition in the context of nutrition-related health. So I'm a member of the Obesity Collective, and as is Tiffany, and there are resources around the world calling on us all to talk about obesity in a person-first language. So what does that mean? So that means talking about somebody with obesity in the same way that you should talk about a person with diabetes. When I worked with families with cystic fibrosis, a child with cystic fibrosis, people are not their disease. And there has been work done to try and disentangle the contribution of body weight to health and well-being. Some of you, I'm sure, have heard of the Edmonton obesity staging system. And it really asks the question then, at any given body weight, what is a person's physical health? Can you walk? Can you do the activities of daily living that you want to? What's your medical health, your metabolic health? Do you have liver disease? Do you have type 2 diabetes? Are your lipids raised? Is your blood pressure raised? And what's your mental health? And if a person is of a higher body weight, but none of those boxes are ticked, then leave them alone. But if someone is extremely impaired in terms of physical, medical and mental health, they deserve treatment. And the issue is, for many people in Australia, they don't even know that there are treatments available. So I think it's trying to make the language neutral and trying to educate everybody about what the treatments are out there that are effective in order to improve weight-related health and those key domains.
Because Tiffany, my understanding of the social research in this area is that if you focus on, we can talk about what we refer to as the problem, but if you focus on obesity and you try and talk people into losing weight, it doesn't chime at all. What chimes is, do you want to be healthier? Do you want to feel better? Exactly as Claire's talking about, is what's your core problem? Your core problem is probably not being overweight or obese. It's other stuff that might be going on in your life.
I think that we can't be black and white about anything in this topic, and some people are motivated just to lose a few kilos because they want to look good. That's not really the space that we're operating in. We're trying to focus on people that want to improve their health outcomes. But people are living with obesity for different reasons. There's many different drivers of obesity. We make assumptions that people aren't trying. I mean, we've talked about it a lot today. I don't need to go into detail about that. But if someone is looking to improve their health, it needs to be a person-centered conversation based on their history, how they want to talk about it. Some people, I'm assuming this is going to come up, but I get asked all the time, what's the wording we should use? And I was like, I'm sorry, I don't have a black and white answer for you. Some people love fat, some people hate fat, some people love living in a larger body or living with obesity, some people find that really condescending and stupid. And whether the topic is brought up should be based on that person's goals and needs and wants. So it depends on that person what they're motivated to do for their own health, and that should drive the conversation as well.
But that's a sort of, well, not but that's an individualized approach, almost a clinical approach to somebody who's
Person-centered.
You know, that's right. But there's also the population-based thing, you know, the issue, and do we use the word obesity in that issue, you know, as a society-wide issue?
I know we're not going to agree on this, but I'll answer on and then I'll go to you. So we made a statement about this, and we understand that some people find it very sensitive, and it is certainly not our intention when we talk about obesity to make people feel characterized or stigmatized or blamed or shamed. Actually, what we're trying to do is raise awareness that it's the systems challenges we're trying to change, and we're trying to focus on the health sector being able to have an educated, resourced, and funded, nuanced approach to this. So we're not actually focusing on individuals. So we understand that it's a sensitive, stigmatized term, and we wouldn't recommend it's used on one-on-one conversations. However, when you're talking about it on a systems level, it's confusing if you don't necessarily, or if you're not clear about what you're talking about. And I don't think taking the word obesity out of the conversation on a national, state, system level is going to reduce the stigma. What is going to reduce stigma is raising awareness of the many drivers, the science, the lived experience voice, and the harms from stigma. And there needs to be understanding. Just telling people not to be jerks is really ineffective, and actually from our focus groups has pushback and blowback.
What is blowback?
As in terms of, so we, for example, tested framing of, you know, you shouldn't stigmatize because that's mean. They almost were like, you know, it almost made them have more of a negative perception of the conversation when you're telling someone about the values that they should have. What we found in our focus groups is that if you talk about the science, the physiology, the environmental drivers, the biology, particularly around, people get really angry when you raise awareness of when you lose weight, your metabolism drops and your hunger hormones go up, and they go, why didn't I know that? I feel like I've been tricked. Or you're raising awareness of the obesogenic environment we have. People find that interesting, and they come to their own conclusion. Oh, I need to think about this differently. But if I go out to that person and say, you shouldn't say obesity and you shouldn't think about it this way, they're going to tell me to go do something, in my experience.
Asmaa is a member of the community, yes. And you're a member of the Egyptian community in Brisbane,
yeah.
With its own culture. I mean, where does this all sit with
Yeah.
non-English speaking communities?
Yeah, so for me, I think language is very important. When my daughter, I get to be with Health and Wellbeing Queensland through my daughter's dietitian. So when I started to feel like my daughter is gaining weight rapidly, and I started to get concerned because me growing up, my daughter have an eating disorder, so I was really alarmed. And I wanted to talk to the doctor, but I didn't want my daughter to hear anything negative, especially that she was really young and she had no idea. So I met with the doctor, the GP, first alone, and I discussed my concern, and then I met the nutritionist alone and discussed my concern, and I brought Nadia into this when I asked them not to mention the weight, or because I didn't want her to associate weight and the number on the scale of being healthy, and the smaller the number is, the better you are. And this was really easy thing that we get tricked into. So
Before you go on, did she think it was a problem?
well, no, at 7 years old, but at 9 years old, when she was 9, yes, she started to talk about it herself. I thought if she would mention it, I can be comfortable for her to talk to the GP or the dietitian about it. But if she had no clue, I wasn't really comfortable to throw this on her way. And also, I think was really lacking and was really important is like how to get the help. When I felt like I need help, I felt like I have no idea what to do. Like when girls are in kindy and we have all these papers with what they do in kindy and stuff like that, if we can have like brochure saying if you're concerned about your kids' well-being, or if you're concerned about their eating habits, you can do this or can do that, that can have been helpful at the time. Yeah.
Fiona?
Yeah, I mean, it's super interesting that the term obesity is being positioned as kind of neutral if we put it in person-first language. But that is not how everyone who has this body characteristic feels. We know from the research that the term obesity is not well understood, and it serves as a stigmatising weapon in itself for people who have that characteristic. Today we've been talking a lot about environments, and we've been using the term obesity. We've really meant obesity rates, actually. But when we use that term obesity, we turn it into a person's problem. And that term obesity medicalises somebody's body size. So as Claire was saying, the Edmonton staging system is an attempt to try to make body weight understood, its relationship with health a little bit more nuanced and well calibrated. But at the moment, obesity is just a stand-in for a BMI of over 30, right? So it is only an element of somebody's weight because our height is relatively constant in our adulthood. So we're calling somebody's weight a disease when we use that term obesity, and it has been critiqued very thoroughly for that reason. And so I think if people are feeling stigmatised, and if that term is being used to medicalise their body, that we should take that seriously, because it's not having the impact that we want, and that is healthier lifestyles, engagement with the community. When you call somebody's body unhealthy inherently on the basis of their weight, what you're doing is undermining their ability to score highly when they're asked about their self-rated health, and we know that's an independent reflection of their mortality risk. And it also is used as a justification for othering people. So no, you can't have this meal, you need that meal, all of the nonsense around food that we end up doing with weight concern. The term obesity, our weight concern in general, is always a label for something else. And my invitation is to ask yourself, what is it a label for? Are you actually concerned about lifestyle behaviours? Then don't hide behind obesity being the signal for that, because it is not a good reflection of lifestyle behaviours, particularly in an individual. It's terrible. But across a community, it does not give us good information about those things either. What it does is stigmatise people, because when you make it, you know, we're worried about obesity, my BMI is over 30, and I've sat here and listened to people calling me a scourge. That's horrific. That impact is bad, okay? So we can't sit and medicalise it and not expect to have an impact that is different from our intention. We need to listen to how it lands.
I think one of the really key issues that you've touched on there is actually the stigma and bias, because we know that that does exist. With my students this year at the University of Newcastle, I got them to do the online stigma associations tests, and I was really pleased when some students said thanks. They didn't even know that that was a thing that you could learn about, and also to raise awareness of their own inherent stigma. And I'd encourage you all...
Sorry, inherent stigma or inherent bias?
They're inherent bias. There are a number of tests. You can do an implicit association test. There are a couple put out by different organisations. And there's lots of documentation on good websites. The Obesity Collective have done a report on stigma. Obesity Canada haven't just done a report. They've actually created a whole lot of resources. But it's stigma that can be internalised stigma. People are made to feel bad, like you've said, so they don't seek the effective treatments that are out there to improve weight-related health.
Well, Claire, they don't seek any treatments. They don't want to go to the doctor. Yeah. So they're delayed. The diagnosis of things that are extremely life-limiting is delayed.
Yeah.
They get hit up for conversations about weight loss surgery when they're having a pap smear. Like, this is how, when you think about every healthcare encounter, if you're a clinician, every healthcare encounter with a large-bodied person, I should bring it up. The effect of that is they don't come because weight is not an easily changeable characteristic in people. We've heard that a number of times through a number of different lenses today. And so you don't want to go back to the healthcare provider who you just nodded to get it over with last time, and you're still in the same body that you have, because you're likely to have that for the rest of your life. That is the reality. That doesn't mean that you're not living well, connected to your community, physically active. It just means that those healthcare encounters are being undermined, the effectiveness of is being undermined, therapeutic relationship undermined by that.
Asmaa, I mean, you obviously were worried about a lot of this when you took your daughter to see the clinicians or the doctor or the dietitian and so on. So you were worried about harm. You were worried about harm.
Yeah.
Did they pick up on this? Did they respect that view?
Yes, I think, yeah. But what I felt like was lacking when I did talk to lots of my friends who have obese kids, that they, even if they go to the dietitian and they tell them what to do, no one tells the parents what to do or how to act, or like you don't, because sometimes parents feel like it's my fault, and then they start to be a bit aggressive with their kids, or they start to get angry over the thing because they feel like it's their problem. When in the previous panel, when they said, no, it's not our fault. It's not our fault that the fast food ads are everywhere in the supermarket.
Doesn't stop parents feeling guilty, though.
So
yeah, that's right. There's actually a really good website called the Butterfly Foundation. They have resources for parents, so parents can go and have a look if they have concerns like you. But they also have programs for teachers as well, and for schools. And I just want to go back to the point about stigma, because I think if you had to start somewhere, go, where will we start in dealing with this? It is actually through educating health professionals on how to have that helping role. Because even more distressing, I would say, is that people's health is being impaired. And not just their physical health, like they're not being prescribed antihypertensives because of inherent stigma and bias because their blood pressure is not being measured. It's also things like not being referred to appropriate services, or not even getting the pap smear because assumptions are made by healthcare professionals. So we really need to up the ante in terms of health professionals knowing how to play a supportive role and improving people's weight-related health overall.
I think we would all agree on this panel that weight stigma is a barrier, it's harmful, and is actually leading us in the wrong direction. And what we've learned is that most healthcare professionals in their standard training don't have lectures about the biology and the environmental drivers of obesity necessarily.
So can I jump in and tell you something? So
go to Newcastle University. Claire, you're going to get it.
But I have another point about ABC making a mistake too. Okay. So afterwards, yeah.
So
we're not going to get there.
Just got to throw it out there.
No,
we did a survey.
That's not fair.
we did a survey of 300 health professionals and asked them about their practice in regard to weight management. Health professionals all said, I want to be part of the solution and I'm having a crack at it. But unless they were a dietitian that had no undergraduate training, extremely limited postgraduate training, so we asked, what do you do? They go, oh, no problem. I just say whatever the last person told me.
Keto diet or eat less and
what
walk
might
more.
have worked for themselves. So we found that they could be in a position to be doing harm. And compared to dietitians, now here's a plug for dietitians, of the Medicare primary care plans, 5 visits to allied health under Medicare, 1 to 2% goes to dietitians. So we never get to talk to people or share what's in our head. So it's really important that we work with our colleagues to ensure they're passing on evidence-based information and not doing that harm, but then they need the stigma and bias.
Okay, Tiffany.
So
hit me.
The zinger. The point I want to make is the stigma is everywhere, and particularly in the healthcare sector. I don't think people understand what that looks like. The word obese was used a lot today, and actually I've talked to a lot of communicators, and we say don't use the word obese. They find that very annoying because then you're gonna have to, it's not short for short snippets of media. But once you realize that that's potentially stigmatizing, you can't really unsee it. And I think there's lots of stuff happening in body language or framing, or if, as Fiona says, if someone goes to a healthcare professional and the next 10 visits, they're told to eat less and walk more, and that's all they're told, yeah, that's gonna suck. But I don't think that health professional understands the harm that they're causing because they don't understand obesity. And ABC, on Friday, I did a bit of TV and radio about stigma, and then they put a photo of a big belly with the head chopped off, and I called them, like, please, you must change this, like, the irony is too much. And they went, oh my God, I'm sorry, I had no idea. And I think that's happening everywhere.
So just before we go on, just if you could introduce yourself, that'd be great.
Thanks. Dom Courtney, I'm from Outdoors Queensland, but I'm also a person who has lived all my life overweight and obese. At one point I was nudging 160 kilos, I'm 6'2". It's not good, but I also, all my life, have had ridiculously good blood pressure, but every single time I've had any encounter with when I donated blood or I'd go to my GP for a checkup, they would always do my blood pressure twice because there's no way that guy has good blood pressure. And you know that. You know in your head you're going to do this twice. And I even used to say to them, my blood pressure's always good, but you can do it twice to check if you like. Because you knew it was coming. And they would do it again because that machine must be wrong because of what their eyes are seeing. And I think it's a real challenge because you get to the point of going, oh, I don't know if I could be bothered donating blood. And that's not good for the medical system either. And I think it's thinking about that sort of system of how people are treated based on something that, as we've talked about, it's a product of the entire environment as well as, you know, some of your other experiences.
Absolutely, and it is the reality that weight stigma is used as it's like a way to downgrade the legitimacy of people's voices with lived experience. And so that double checking blood pressure, what can't be true. People also, you know, assume that a larger body person is lying about their dietary intake if it doesn't, you know, match the stereotypical idea about what a larger body person eats. And actually it's the same as everyone else, basically. Smaller body, larger body, no one's eating very well. And it also permeates into all of there's a lot of gaslighting that goes along for larger body people when they're disbelieved. We've got a panel here that isn't represented by people who are impacted by weight stigma. People in the room.
Be careful the assumptions you make.
No, I'd like, in general, we will all be able to access most healthcare, but for a third of the population, the healthcare system they interact with is not the same as somebody with a BMI of 22. Here in Australia, we've got geographic disadvantage. We've also got a high level of healthcare rationing and holes in the healthcare system for larger body people. They can't get their knees until they have weight loss surgery, for example, this kind of pattern, instead of us putting our attention into realising that weight loss surgery is not all rainbows and butterflies and great outcomes for everyone, there are nutritional consequences of weight loss surgery, even if they have a good outcome. And we're putting all of our attention into today's topic instead of realising, well, actually we should be putting a lot more R&D into helping people in the bodies that they have right now, and that would be helping people to access new knees, new hips, IVF. There's a whole heap of healthcare services that are rationed, and it's because training does not involve a representative sampling of the community that the doctors will have to work with when they get out the other end of their training. So this is the impact of weight stigma. That's what that does.
So Tiffany, what were you going to say there earlier on?
Oh, I think we need to be careful making assumptions based on someone currently sitting here, what their history is and experience of weight stigma, based on an image or someone sitting there.
Thanks for that, Tiffany. Thanks, everyone, for your comments. I think one positive thing that could be done, because stigma is so inherent, is, you know how many times when you hear people talk about suicide on the news, they always qualify it with where to get help. But we don't do that for weight-related health. And we don't have that comprehensive education so that doctors feel confident to support their patients in weight-related health issues. Now, weight-related health issues can also be invisible. I've just been at the International Congress on Obesity 2 weeks ago in Melbourne, where the biggest concern and a big impact for healthcare is actually going to be what's now called, used to be called NAFLD, but MAFLD, so metabolic associated liver disease. So when fat is stored in your liver and in your visceral area, that's the biggest predictor of whether you'll get the health consequences like type 2 diabetes, for example. And this is being missed. All of this is being missed. So we need a way that's empowering for people to talk on it. There are image banks. You know, the International World Obesity, they have an image bank. Obesity Canada have an image bank that journalists can use.
Just before I come to you, I mean, you talked about, I mean, the International Obesity Society and the local Obesity Society, you know, they're largely doctors, some biological researchers, but they're mostly doctors, some nutritionists in there. And they've made a big deal over the last few years that this is a disease. And that seems to me to be extraordinary. It's something promoted by the pharmaceutical industry, because if you've got a disease, then we're going to have a drug, we've got things to sell to you, and it doesn't help stigma in the slightest, that this is, you know, calling it a disease.
Well, I'm going to disagree with you, because if you are Edmonton obesity stage 3 or 4, so you have hypertension, you have high lipids, you have chronic kidney disease, you already have had polyps removed from your colon, and in order to improve your health, you need assistance to manage the drivers of that. I think that pretty much is a medical condition that requires treatment. So why would you not treat and support someone? And in case people don't know, there are medications that are coming that like tirzepatide, the trials are starting in Australia, that will actually be as effective as the results of bariatric surgery, which currently is the only long-term effective treatment for people who are suffering. They're suffering. They can't necessarily, if you're so impaired that you can't participate in the workforce, that's a disaster. If you have osteoarthritis, debilitating osteoarthritis, your income is likely to be a quarter of your counterparts who don't have the osteoarthritis. So we can't pretend that it's not affecting people's medical health, because it seriously is. And I think we need to be committed to improving people's medical health so that their well-being improves.
But let me just come back at that for a moment. There'll be a single person in this room that would say, if you can mitigate the consequences of obesity, you should, and treat it and get down to it, and fatty liver disease and what have you. But coming back to your question earlier, is somebody who's basically quite healthy, and it was in fact your opening point, Clare, somebody's quite healthy, but they've got a BMI of 30 or 35, do they have a disease?
No, then you don't have a disease.
But the Obesity Society says, yes, they do.
I think you'll find that people will move towards what's being more and more accepted internationally is a staging system. You know, I think you've heard from all of us that one term, you can't use one term and have multiple meanings of that one term. You need a way to assess degree of impairment across those three domains that I mentioned. And you know, to a point that you touched on earlier, and everybody actually needs to improve their nutrition-related health and their physical activity-related health if we really want to live our healthiest lives and improve our well-being.
I personally find the disease topic super annoying. I'm constantly attacked that we don't call it a disease. I'm constantly attacked that we might call it a disease. It's really distracting, I find. And when I talk about the physiology that people use, the underlying logic as to why it would be a disease, people find that fascinating. But if you say the word disease, then we're having an argument about what is a disease and what, you know, and it's just a distraction, and it splits the room of experts, and then we can't get stuff done that's important.
I'll just take the comment. Yes.
Thank you. Public Health Griffith University. It's all about framing again whether this is an individual responsibility and then someone should just shape up, or whether this is the environment that people live in that actually makes them sick, whether you call it a disease or a condition. So I was struck by one word, for example, lifestyle. The way we talk about things matters. So lifestyle, to me, if obesity is the consequence of a lifestyle is something you choose. It's a bit swanky, so you choose a certain lifestyle and therefore you live with the consequences. So that's the framing of individual responsibility. You could say, okay, because of the circumstances, it's not about lifestyle, it's about options that people have in life, and for many people those are unfortunately limited, and so their behaviors are then shaped by the environment they live in. So should we be using the word lifestyle for the kind of changes that we want or the behaviors that we are trying to address?
And the lifestyle issue is that the driver of the stigma, right? These assumptions about how a certain way of living might be reflected on somebody's body, and that is what's driving stigma. We as nutrition professionals know that you can't take somebody's dietary history, sight unseen of the person, and predict with any degree of accuracy what that person's body size is going to look like. If anything, people's weight is a historical remnant of previous behaviours. It's in no way really reflective of current lifestyle practices. But that is what the community believes is happening, and that's what many health professionals believe is happening as well. And I mean, the lifestyle term is problematic because the individual, but so is like obesity puts it on the individual. In all of these terms that we have been using today have individualised the problem.
So I'm not sure, do you take an absolutist position here?
I think you're asking me whether I believe that weight can ever affect health. Is that
No,
the question?
No. I'm asking about the word.
Yes, I do take an absolutist approach. I work with larger bodied people in the fat acceptance community. It is seen as a slur in that community. There's no buy-in at all. We do have diverse viewpoints on this, and the community, the fat acceptance community, is coming. It's grassroots movement. People who've been stigmatised and discriminated against versus big pharma medical model thinking. So it's an important thing to understand that distinction. Who wants the narrative to stay with the term obesity and with treatments being offered that are wholesale around weight control and weight management, versus who would like to see people more well supported in the community, including means to enhance their health outcomes without pursuing weight loss. That's the difference.
Look, we've changed our language around transgender, around LGBTQI, and that's been driven by the community. So there's a community of people who says, look, I'm queer, get over it. You know, I'm gay, I'm lesbian, or I'm not identifying, I'm loose identity.
They took the term back.
Sorry?
Took the terms back, right?
Yeah.
Yeah, so fat's been reclaimed in a similar way in the fat acceptance community, in that it's a term that's been used as such a barb and insult to them through their lives, and to reclaim that is a very powerful move. So yes, I mean, it's a descriptor of my body. So in the same way as tall, short, all of those descriptors. It's the way that it's used, the intent that the word is used with, that is incredibly important. And I think if we just removed the word obesity, that wouldn't change weight centrism. We need to understand what those, what the narrative is driving at.
Sometimes I wonder if we did remove the word, would that facilitate people actually getting the medical help? Because what I'm talking about is people who don't know that they can get help for their medical conditions when they're entitled to them, and they don't get them because of that bias.
I just want to
They
come to
can't get
Asmaa.
help for the medical conditions they have.
What I really find that is lacking is the psychological support for the people who is, for the parents or because like the adverse childhood experience is the number one reason to have chronic disease when you grow up. It's not being like the obesity as much as like what you go through. So I feel like I miss in the conversation, how can we support the parents or the people who's going through obesity?
Which is Lauren's point, that you have to have a pathway through this where people don't fall between the cracks.
Yeah.
Yeah.
In terms of the prevention thinking versus medical care, what we need, and the clinical guidelines are being updated. I don't think it's public yet, but we need a stepped care model. And as I started with, and that's based on that person's situation, their needs, their personal goals. That means they need to be informed about the evidence of all the different options that are out there, which is not what happens. People are given diets where we know they might lose, if they're successful, 5-10 kilos, and told to lose 30, and then it's their fault because the evidence isn't shared, and it isn't a shared person-centered conversation. For that to be possible, I mean, as I said, the system is not educated, resourced, or funded to do any of those things. So it's not that people aren't purposely doing that and they want to be harmful. It's just we haven't come from that approach. What we need is a stepped care model that starts with kind of if people want to make their behaviors, but then there are people that they have tried 50 diets and their level of obesity seriously impacts their health and well-being to the point that we've heard people that they are going to die from their obesity. And again, it's a smaller portion of people. And so we would not recommend certain things, but for them, they need multidisciplinary, non-judgmental support that is more complex. And sometimes that's driven by trauma, intergenerational stuff. It's not black and white and it's not straightforward, but it's not one or the other.
And Tiffany, the reality is there are very few of those comprehensive services in there. But, I hope Health and Wellbeing Queensland are super successful because I think you're really raising all of these issues and making them public. But one of the things that came up this morning, which goes to the point made up here, is that we're going to have to go back to the 1970s in order to turn things around and save the kids, essentially. So in the 1970s and the 90s, 80s, we didn't have a lifestyle. We walked to the train station and got on the train, and there were no packaged snacks. Like I remember when they all came in the 1980s. So I think I fear for the impairments in people's nutrition-related health, which add then to the weight stigma, which add to the concern of parents because the kids nag for foods that all the other kids are eating. So we really do need some big solutions and very brave decisions if we're going to be able to ditch lifestyle and just head back to the good old 70s and 80s,
Which is
all the hairdressers will be keen, those perms come back.
Which is what we were talking about this morning. Robin?
Yeah.
I've got a question. I've got a question. So I've been.
Have you got a question?
I've got a question.
Good.
And I've
Well,
got
if
the
you've got a question,
microphone
let's
now.
hear it.
I will look out. No, I was just going to say, I've been a dietitian for 25 years and I've seen kids for those 25 years. And I've got to say, then the number of kids that have come to see me, and like I said, they never ever look at me. They walk in and there's this guilt and shame, and they have been to see a doctor or they've been to see a dietitian or someone, and they have raised weight and they have done it in the wrong way. So for them to come and see me, they have been terrified to walk in the door because they know that I'm going to raise weight, and I do it every single time, and I am trained in this and I can do it really well. And I've got to say, I've never had a single child and a single mum or dad that has said to me, "Oh, I just wish that you did not do that today." For me, it's allowing them to lead. And Asmaa, you are completely right. There are so many mums and dads there that go, how do I know? What do I do? Is there somewhere for me to go? Clinicians need to know the way to speak about weight, whether they use the O word or not. I get that all the time, and I use it. I'm sorry, but I completely do. Never ever to describe a person. Never.
That's the effect
Have
it
I
has,
done
though,
that?
Rob. First word today, official word was obese. Like, great. Today's going to be fantastic. It has been really good, but the narrative has been really negative.
Fiona,
this is
I think
deficit-based
Fiona,
talking.
I think you've missed the point. I think that for me, it's really, really important to stop and listen. For me, it's these mums and dads and kids, and I mean the most difficult situations, and they have gone to people to ask for help, and nobody's given it to them, or they have done it completely wrong. And these people have written letters back and said, "Thank God you spoke about this, because I have wanted to raise this so many times."
My question for the panel, and to finish, just picking up on this. So we've really focused a lot on the clinical situation, on the individual presenting forward, on the lack of care that people might get, partly because of stigma, not recognizing the pathway they might be on. But what we've spent today talking about is an activating campaign. We're talking about saying, shit, because of obesity in childhood, we're going to see a decrement of 4 or 5 years in life expectancy, to get some movement on the socioeconomic determinants of obesity at a political level. So is it illegitimate to do that with the sensitivity that we've addressed? Tiffany?
I actually was interviewed just ad hoc from someone on ABC Radio a couple hours ago about this and what I thought about it. And I reiterated that there's many complex drivers of obesity. I think you always need to, before you start talking about the epidemic or the harms or this or that, because that can be triggering for some people, you talk about the many drivers so that it's not just people have a role to play in their health and well-being, but there's a lot more going on here, and we need to stop oversimplifying obesity because we just don't understand it, and that causes harm. But what I said on the radio was, this is a tangible example of the unhealthy environments that we've created, stealing years of life from our children, and people should be outraged, and they should be calling their policymakers.
Asmaa?
I'm not sure. I'll pass.
Nice, an honest response. Fiona?
I'd want to keep focus on environments that support people to live well and move well, no matter what bodies they have. And
But we've
the
got a
living well
political
part,
issue here.
We do, but again, when the focus is on body size and mortality is the kind of Chicken Little situation going on, we are making invisible the fact that the health system doesn't well support larger bodied people now, and where the messaging feels like a political handball. It doesn't feel like it's actually person-centred. So the people who are buying into, yes, this is a major problem, are people who already have stigmatising views about larger bodied people. And it's a pretty crappy way to get a public message through.
Is it really? We're
Well,
saying
you
we've
talk
got
about
an
Magda's trolling, right?
We've got
This
an
is that.
obesogenic environment. We've got the structure of the world we're in now is one where you put on weight which you didn't put on 30 years ago, and that's causing all sorts of problems for individuals, for the community at large. And the solutions, if today's not been a total waste of time, are social, psychological, political, economic. To actually, we're talking about primary prevention. And therefore, to activate, maybe you've got to use dramatic terms.
Yeah, but not that it is in a way that's going to harm a third of the population. That's why this session is on, because it is a important consideration. People feel it because they feel uncomfortable talking about it with people, right? It's there. This is the issue. And I think if you're going to make political point scoring at the detriment of a group of people that you're saying that you have the health in mind of, it's really a topsy-turvy, unhelpful way to do it.
Claire?
Yeah, so quick point. I still think we need health professional education so that people who are seeking treatment are able to voice that and get access to the treatment. But I think ABC must have been running hot today because I just did an interview before. So
And I have one tomorrow.
yeah, so
We've got nobody
I
else
use
to
what
interview.
came up is if we really need to go back to the future, then we need government, and even if it is federal, to stop backing away from talking about taxation. You know, like, we've got to go back to, people forget that when the GST came in, there was a 20% tax on junk food. There was a 20% tax on chocolate and soft drink, and then soft drink suddenly became dirt cheap when it only went to 10%. We've got to gradually build up the taxation on those items in order to fund all of these extra activities that we've supported. And I told them the same thing. All you parents listening, you go and talk to your local minister, whoever gave us that tip. We need this to come from the community to say it's not acceptable to treat us like this, make our lives so hard.
Please thank our great panel.